Welcome everybody to the third session of Crisis Care Continuing. We'll be starting in just a moment. I'd like to remind everybody that the microphones are muted and your cameras are off. This is being recorded. If you have any questions or comments for the presenters today, please put them in the chat box and I will present that during the question and the answer portion that will immediately follow the presentation. We will begin in just a few moments. Thank you. So for those of you who are just now entering, we'd like to remind you that the microphones and cameras have been muted and they're turned off. The session is being recorded. If you have any questions or comments for the presenters, please put them in the chat box and we will present them to them at the end of the presentation. If you do have any technical issues during the presentation, our CVent host is here to help you with that. Please put your query into the chat box. At this time, I'd like to introduce Charles Browning and Joy Brunson and Subaga. I'd like to say that the views, opinions, and content expressed in this presentation do not necessarily reflect those of our funder, the California Department of Healthcare Services, or our CARE TA Center partner agencies listed below. In the case of any security issues that may occur, this session will immediately end and will not resume. A separate email will be sent to all participants with further instruction. Thank you and enjoy the presentation.
Thank you. I'm Joy Brunson in Subaga, and I am the Vice President of the Southeast region for RI International. I oversee North Carolina and Louisiana as a part of my region, and I have been working in the crisis center space for the last 7.5 years. I mostly focus on access for everyone for crisis services, as well as MAT treatment as well, and substance use treatment, as well as equity, inclusion, and diversity for organizations. And so I'm going to pass it over to Chuck to introduce himself.
Hey, everybody. I'm Chuck Browning. I'm the Chief Medical Officer at RI International. I'm also the Medical Director of Behavioral Health Link in Georgia, which does 2 other lanes of crisis now, including crisis call lines and mobile support teams. And I dedicated a lot of my life to working in crisis and crisis systems and worked with RI as an actual on-the-ground provider early in 2009 and since then. And one of the important things to me is talking about the fusion model, which we describe as the fusion and blending of the best parts of the medical, biomedical world with peer support and peer-powered practices.
Thank you, Chuck. This is the third session in this 3-part series that we have been doing today on the crisis care continuum. We started with there's a crisis in the system. The second workshop was the tipping point. And now we are going to present shaping the future. And so over those 3 workshops, we have had 3 learning objectives, and they are providing attendees with data and real world examples of research and context for the crisis system in the US, providing information on the intersection of disparities and inequities in healthcare, and providing the most up-to-date information on innovation and technology in the crisis continuum space. So like I said, this is the third session in this series today. Just to give a little bit of background, because we really want to spend most of our time on what the future will look like. But all the sessions are connected. And so for the first session, we talked about the historical perspective of the system, the gaps, the issues, how it was set up for behavioral health care, and then also some of the barriers that we have identified as gaps that we need to address and interventions that we need to put in place. So that was our first presentation. Our second presentation was on the tipping point. What has happened in the last year that has really catapulted organizations like RI International, the one that we work for, and other organizations that have started to look at how to overcome those gaps of care. How the last year has definitely catapulted that through the pandemic, with the increase of mental health concerns, and then also social unrest and the demand for equities in the system. So that was our second presentation. And now we're going to focus for the next hour on the future. What do we see as important innovation and interventions for the crisis continuum as we move into the next year? And then also, what are some of the barriers that we still have to work out and overcome?
Oh, Disney. I get to talk about Disney.
Disney, yes.
So I'm definitely a Disney freak in terms of enjoying going down to Disney World. I know you guys have Disneyland on your side of the country, but this is an area in Epcot and Disney World called Spaceship Earth. And for those of you that aren't familiar with that ride, you go inside this big metal-looking golf ball, and there's a cart that goes around in a circle on a ride, and it simulates a time machine. And so the journey through animatronics and things that you see is how human communication has evolved and affected and interacted with human development and society as time has gone on. And as you can go to the next slide, Joy. As you get to the end of the ride, you've got this touch screen on the front of your cart that you're riding in, and it encourages you to pick things out of your future that you would like to be in your future, whether it's going to be, to live above ground or floating in the sky, how you want to try, what are your favorite things to do on vacation, that type of thing. And it takes a picture of you on the ride, and that's not my head, that's just a random person's head on that screen. And then it plays out a kind of a showcase of what your future might look like. And so it's an enjoyable thing, but it's very apropos, because what we're going to talk about today is, if you are designing a crisis system for your future, what elements would you like it to have? How would you design it? What would be the things that you would put in it? And so when we think about when I think about really important things like access to care for everyone, so that there's an equivalent parity to what we have in emergency medical care systems, that no matter what your insurance situation, where you live, your race, gender, age, that you can go and get care. And that when you get that care, that it is trauma informed, and it's less likely to traumatize you more, but more likely to help be calming, comforting, caring, and help you de-escalate your crisis and get support you need. That it will be fit the level of care that you need, so that you don't have to just go to a hospital or go back to your community, but there's multiple different layers of both preventative and post-venting type supports on either end of the spectrum, and that there's layers in a continuum of the care that offer you choice there, that you aren't just a piece of a process, that you actually get choice and say so and voice in your care in the crisis system. So there's many elements that when you think about, if you wanted to design a system that made sense, that you would include in that. And we are at a place, as we talked about in the last part of part 2, of a tidal wave of momentum of the potential to be able to move forward and do that. So when we talk about where can crisis go, if you've been in part 2 and part 1, one of the things that we've really talked about is this element that, at least if you want to be able to create an element for the system not being stuck with people ending up either in jail or waiting in emergency departments, you at least have to have a functioning crisis receiving center that can accept everyone like an emergency department does, without and has the infrastructure ability to do that. But where crisis can go is not just be able to have the infrastructure to do that safely, but also make it a very recovery-oriented care process that would be the kind of care you would want to be for yourself or your loved one. And that's the challenge and the tension to do that. And so we call our strides at doing that the fusion model of blending the best things from the peer recovery world with medical model best practices and things of that nature.
And so as we're thinking about how we're setting up the system or where the future can go, we really started to think about the sequential intercept model, which is being used across the country as far as an example or a roadmap for the legal system to be able to develop interventions at different levels as someone has entered the legal system or has been involved in the legal system. And so we talked about earlier how when you call 911, law enforcement gets involved as the first part of that system, where in the second part of that system, you call 911, law enforcement get involved, but they're able to take you to a place that is behavioral health focused. And then what happens when law enforcement doesn't get involved? And we have a separate number and a separate system for someone with behavioral health needs to call and get access to mobile crisis. And so really looking at this sequential intercept model for the legal system, we would be truly at intercept 0, which is where we've got a functioning crisis system, crisis lines, and then access to care that is ready and available for individuals who are in need. So that we don't get to the other parts of the intercept, the intercept model, which we feel is the most important. Chuck, would you add?
No, I think it's right on, and it leads into this next slide about 988. And so I think 988 offers such an exciting hope for the future about putting so many more calls that typically have been going through 911, which then activates law enforcement, instead connecting that group of people, those millions of people across our country, to behavioral health specific care. So this slide represents currently right now, we get about suicide prevention lifeline. It's about 2.5 to 3 million calls. Local, county, state crisis lines, about 13 to 15 million. And then there's a conservative estimate that about 10% of 911 calls are behavioral health related. And so you're talking right now, and this is a very conservative estimate of 40 million calls that could potentially go down that sequential intercept 0 pathway. Now, the other piece that's really interesting to think about in the future is what happens if there's public education about 988. And now people feel if there becomes a system that people can trust, that they know if they call 988, they're going to be getting specific behavioral support help. How many people don't call 911 that are dealing with suicidal thoughts or things like that may change? So there's multiple factors that are hard to predict at what 988 could mean in terms of volume. And so this is a very conservative estimate, but just in thinking about that one factor alone, numbers could be much larger. And so as we look at the future of 988 and how it works together with this system, I think one of the things to think about is what's coordination between 988 and 911 going to look like. And I'll give you an example. A convenience store owner has someone maybe challenged with symptoms of psychosis in their store that's doing behaviors that convenience store owner gets worried about. And they're not doing anything dangerous, but they're acting bizarrely. Maybe they grab something off the shelf like a banana to eat a banana because they believe that only food they can eat needs to be protected in a natural shell, and they're really hungry. And so in the future, will that convenience store owner know that this is a behavioral health issue and call 988, or are they going to call 911? So you've got a public education factor to think about. The other piece to that, though, is how can we improve the coordination as we open up with 988 and 911 so that if 911 does get that call, they hear what's going on and they can say, I need to route this to 988. And so there's already some different states, even in this past year of movement, that are working towards looking at coordination. And on the 988 national call, there was someone, Joy, that talked about, and I can't remember what city or state it was, but is opening up where they're going to be answering 911 calls. Is this a fire, emergent medical, law, safety, or behavioral health concern? And that's going to start that route tree right away. So there's the future of 988 is just unbelievable in terms of what pathways it can open up, but there's going to be things in the future to figure out.
Absolutely. Yes, lots of opportunities, but needing the right coordination and in response.
Oh, you went to Star Trek. So speaking of coordination, one of the things you think about in the future is air traffic control, and how is technology going to impact and be interwoven into what we do. And so, it's not that far away that this like Star Trek command center idea is going to be have the potential to have an impact on the way that the crisis system works. It makes sense. It would be cost effective, and it really would offer the best air traffic control for a big system for an area to know where people are from the start and the end of their journey and their crisis system, and the fact that they're intersecting with these different levels. And if you'll go to the next slide. So this is another example of NASA tracking things and the people that are responsible for guiding it. But the next slide coming up, if you see, this is actually being done in medical healthcare. So this is Gold Coast, Australia. This is an example of the hub that they use to manage the population in their area, to track lots of different data, metrics, productivity and efficiency and quality measures of their own healthcare services. And this group of people are constantly monitoring these systems in a NASA Star Trek-like hive. I predict the future is going to offer, there already are technologies right now that can do some amazing things in terms of knowing what's available in bed tracking, GPS location for mobile support to know where to go and to pull the closest one. When you're out at 2 o'clock in the morning and you're a mobile support person and you're trying to connect someone to an appointment the next day that's appropriate, there are technologies right now that connect people, have open appointments listed for what's available that matches your location, how urgent the appointment needs to be, what your insurance is, and uses technology to take care of all of those things. So I think there's going to be a lot of room in the future for technology to help support and coordinate those things.
Yeah. So historically, when it comes to data and technology in the behavioral health field, there's been strides that have been made, but there's been a lot of opportunities to opt out, concerns about confidentiality, concerns about going against someone's wishes and desires in that moment. And so really we'll have to look at how technology can be used, but also to inspire confidence in the system, to be able to eliminate those concerns, address those concerns, but also kind of overcome those barriers in the future so that we can use some of the technology that's been used by other systems for years to enhance their efficiencies and effectiveness in the work that they're doing. This will have to be a part of our future.
And Joy, one other thing that you that while we're talking about technology, because I don't know that it's going to come back up in any of our other slides, the pandemic has brought forward a lot, two or three major things that I think are relevant to bring up and talk about when you're considering what your system looks like. One is the use of psychiatry and tele connections. It offers opportunities in more rural areas to get expert opinions and supports out to someone, or when transportation is an issue, being able to connect there. I think the future will involve a blended mix of in-person and tele based on consumer preference, logistics, and things of that nature. However, it brings up one of the issues that we're here talking about today is disparities. If different populations, especially low-income populations, are not allowed to have data and access to smartphone type things, then they could miss out on not being included in a lot of the options of data that you might see available that some of us might consider commonplace. Different apps, connections, teletype options that they could use that could be very helpful for healthcare improvement, but it's going to bring a decision point for our future as a country is what do we do with data for everyone? And what do we do with cell phone technology and things like that?
And I think that is something that's on the forefront that has been talked about over the last year with just, Chuck and I are parents, just as that switch of the school system, you're talking about rural communities and communities that didn't have the same access to resources, and how were we going to creatively make sure that everyone had the same opportunity for education and support and still be safe at the same time. So these are questions, considerations, and really expectations that we should have of our system to be able to support every individual that's in need, but also bring those questions to the forefront so that we're able to address them, work on them, and overcome those barriers. And that's going to be something we're going to have to do in the future. So the future of care is really where we would like to go next. The use of technology, having the overall services in place, and the expectation of, the call center, the mobile crisis team, the crisis receiving center, the use of technology, all of those things are going to happen. Where it is important is to look at the actual care that is being provided. Because unless we look at the actual care and treatment and training and expectations of those services, we are going to repeat some of those disparities that we've seen in the system, excluding certain communities that we've seen in the system. And then also we're going to have a system that is set up that is not meant to serve everyone. And so over the next couple of slides, we're really going to be talking about what that care that is involved in those services should look like, and how that should be an expectation in the future.
So Joy, this looks like, oh yeah, so this is the National SAMHSA toolkit for behavioral health crisis care. And one of the things that often gets overlooked is this essential care principles that are outlined. And I talked about these briefly in part 2, but it's addressing recovery needs as part of a crisis response and part of treatment, significant use of peer support, a heavy lean into trauma-informed care, because so much times trauma and what someone is bringing to the table when they show up in a crisis is such an important part of how well that service is going to help that person be supported in their crisis. Suicide safer care or zero suicide principles, having safety and security for your staff so that they can do the work to be connected, engaged, caring, and compassionate when they're doing it. And then finally, as we talked about in that 988 situation, is good coordination between law enforcement and emergency services at those different levels.
And overall, starting off the premise that when someone is in a crisis, that it's an opportunity, not going directly into what's wrong, trying to figure out, diagnose, and medicate, and kind of go to the target of what we think may be the problem, but really get in and engage the individual, listening to that individual, and seeing this as an opportunity to work with them to get them to where that they need to be. More often than not, when someone is in crisis, we focus on what's wrong and then determine if that something that's wrong meets the criteria for what we feel like their care should be. And if it doesn't, then they are excluded. In the future, a crisis should be what someone feels that it is to them. And if they feel that they need support, then looking at that as an opportunity to provide those resources, that support, that engagement that is needed in that moment, and to support someone when they are in need, and not to have the judgment placed on, are you in crisis enough? Reaching out and asking for assistance, or noticing that something is just a little bit different should be enough for someone to receive the care that they need when they're asking for it.
Well said, Joy. Is that me?
Yep, you want to jump into this one?
Sure. So, a big premise of trauma-informed care is these principles. Oftentimes you'll hear people say trauma-informed care is about meeting people where they are, but actually practicing it and then executing it as a team is not an easy thing to do in healthcare. To have a consistency in every staff member being able to be engaging, to be able to, and this is again why we talk about the RI way being a lot like Disney, and that we want our staff to be able, when they come into work, to get centered and be at peace with the things that they've got going on in their life. And it's kind of the show. Once you get on the floor and you're going to start engaging and working with the guests that we serve, you have to be able to have that where it is so that you can be in character of serving. And your character is an experience of creating care and compassion for the people you're serving. It's the way you look at them and connect and engage, and then the types of way that you engage. And so I see the future of trauma-informed care is how do we help support the growth and the ability to do that. It's really hard to do in healthcare organizations. Some of the inner classic traditional things of healthcare create problems for our staff, and that they sometimes get more focused on efficiency and certain performance measures over that caring, compassionate focus. And so finding that fusion balance of how to do both well is really important, I think, in having exceptional care that connects to people and helps them improve. And then I think the other piece of the future, and we've talked about this, Joy, in some of our other parts and portions, is continuing to understand and evolve how to create diversity in our staff and in our staff's understanding of different cultures, different considerations, so that we're creating the most inclusive, connecting, supportive environment as possible for all groups that come in. And we've got a lot of growth and work to do on how to do that, how to understand it better. One of the best ways, and it's been an important part for us at RI, is through the voice of folks with lived experience. So people and peers on our site and within our staff being that voice, peers at a leadership level on our executive team or board members or on our peer leadership council, but also people in the community, families and other users of our services, co-design, helping as you're thinking about your system, how can you build that in to creating these core principles in the culture, hardwired as to what you do in crisis care at all three levels. The call lines, you should hear voices that are caring and concerning, not just going through a script in a robotic way. And in mobile support, you want to have people that have that ability and to connect and be caring with people, and then use the competencies of the clinical tools and things to be able to do things that help de-escalate crisis.
And Chuck, while you were talking, it just made me think of those things can be really opposite, especially when you are looking to make sure you are person-centered and make sure that you meet people where they are, requires flexibility. And oftentimes we put in mechanisms to control the things that we don't necessarily understand, or the things that we feel make us unsafe because we don't understand them. So being able to kind of move over to flexibility, being willing to listen, and I may not know up front everything, but I'm willing to walk alongside you and to support you, keeping myself safe, keeping you safe, but letting you have that autonomy to let me know what is right for you in that moment. And one of the ways to do that is, or one of the ways that we've done that over the last year and will be so important going into the future, is really looking at who has, as Chuck said, that voice. RI is very known for having the peer voice, but most recently, we've also put a lot of effort and emphasis on that diversity and equity voice. And by making sure that where decisions are made, and making sure where policies are made and questions are asked and growth opportunities are looked at, all of those things, and how we do care, making sure that there's more than just one voice in that room, and making sure that there's space and time for questions, challenges, and also to make sure that there's space to bring awareness to different situations that might be missing. And going into the future, we're going to have more of that in order to continue to move towards that flexibility to ensure that we're meeting everyone where they are, and we're not focusing more on control versus that individual care. So you look like you wanted to get started.
Oh, no, go ahead. I talked about that a little bit in part 2. So go forward.
Yeah. So again, this slide is just one that I absolutely love, and it really just puts more of a challenge out there to a place where it is no longer acceptable to have spaces where everyone cannot come, or services that are not designed to support. And I think back to hospital settings, ED settings, and rules that had to be put in place where if someone comes to you, you have to serve them. It wasn't acceptable to turn individuals away based on insurance or need or all of those things. EMTALA laws were put in place. You have a responsibility, and so in the future, as we move forward, having those services, having that training, having that expectation that we are here to serve, I think will increase the confidence to the system, and increase the confidence that the behavioral health care is what it needs. It is for everyone, and it is competent to serve the individuals that it is designed to serve.
And then, Joy, I think the future brings not just access, but an evaluation using data and technology, and a desire and a motivation to understand this is to look at not just access to care, but is it good care? Is it care that's perceived by different groups and different persons to be supportive and helping them improve their crisis? And that's something that we don't do in a lot of areas of healthcare. We have this, patient satisfaction surveys, but they might not necessarily, I don't know how effective they always are in capturing a true experience of what someone is going through, and is the work that we do help that. And so I think the future is going to, I hope, evolve and be able to show a better way with that.
Absolutely. Yes.
So this is an example of some of the care things that we do at RI to try to help support this engagement concept, as well as this trauma-informed care concept, through peer power practices. And so one of the things that we talk about is collaboration as one of the peer power practices, so doing things with people so they're partners in their care and they're the experts of their individual self in their crisis moment to guide. So one of the things that we do is, we have in medical school, you get trained certain medical things that you're supposed to do. And if you're not in nursing, we get the same type of training. And if you're not careful, you can quickly in a crisis situation do things to people as the process instead of doing things with people. And so we actually created clinical guides that give support for our different staff members on ways that they can connect and engage during a med pass or during an interview, during an assessment piece. Here's tools that you can use. We did top 10 questions from guests to give our staff awareness of what are the top 10 most questions that we see our guests ask our staff about. When do I get to go home? Why can't I smoke here? Why can't I use whatever thing that's going on, or what's the next thing that's going to happen, to help guide preventative things by creating expectations through early morning introductions to who's going to be working with you, what the role is, and the expectations of the curriculum of the day and things like that, to as much as just when somebody is upset and has an answer, that we have a core framework, not a script, but just a framework to think about the way to answer a question that gives a consistent answer amongst all staff, but is validating and helps give people choice and do that. And then the last thing that we've changed, and this is really important in your crisis system to me, is that oftentimes somebody will go in different stages of their crisis talk and as they're working and they see multiple different people and have to tell their story over and over again. And it's very frustrating, but it also can be traumatizing. Have to do that more than once. And so we've changed our entire electronic health record to work so that when someone gives in information at once, it feeds into certain portions of the next note to maximize the chance that that person's not going to have to say things over and over again. So as a provider, if I was doing a psychiatric evaluation, I'm going to have nursing notes and clinical notes and peer notes kind of information all in my note already, and be able to then just flesh out certain things without making that person have to repeat all of that over again. And so it's, language drives culture. The way we talk with each other and support things has a big effect on how hardwired you are. So I think in the future, I hope that's going to be a big focus for the designs of your systems.
And following our care guidelines, I'm going to ask you if you're okay.
I got it's a hot, muggy day in North Carolina, and it is getting dry, and my water's gone. And I can't get up in the middle of the presentation, so my voice started cracking on me. Thank you for asking, Joy.
Oh, of course, of course. We've talked a little bit about the peer role, but the importance of having individuals with lived experience involved in all of these settings, and lived experience, whether that's mental health, substance use, family member, youth, all of those experiences are so valid and important, and really allows for someone to connect and understand where someone is and what they're going through. So really putting emphasis on that peer role, and we're not saying having a peer on staff. We're saying having integrated into practices, roles, principles, services, all the way through from start to finish, individuals that have been there and have that lived experience, as well as having peers in leadership roles so that they're able to provide voice, influence, perspective to protocols, rules, policies that are being created, so that there is inclusion from individuals who know what is most important when someone is in a crisis, and what the services need to look like in order to be supportive. And then also some integration of some new tools that include that peer perspective into not only the service, but into tools and assessments that are involved in documentation in that medical record, and an important piece on how an individual is doing while they're in care with a mobile crisis team, when they're in a facility on a call. All of that stuff is really important to have. So Chuck will talk a little bit about some of the engagement and tools.
Yeah, so we've developed this tool that we're enacting now and using, called an engagement scale. And it's basically, it's not part of the person's medical record for the staff to see, but it's done by our peer staff with a simple 3 questions done each shift for our guests that we've served to be able to give opinions on how well they think our staff is doing in these 3 areas. So the first is a measurement of how collaborative is our staff, so that even if you have somebody there on involuntary commitment against their will, do they feel like they're having some voice and partnership in decisions on what they want to do in collaborative safety planning to be able to come off a petition and be safe. And that's a really important thing that we're targeting to be very intentional on measuring how well we're being perceived in doing that. Secondly would be how well are we doing in helping people support and connect people in their community, and because that's a big part of one of our peer powered practices. And then finally, and this is the big one, is am I feeling cared for by staff? And we want a 4. We don't want a 3. We don't want a 2. We want a 4. And that is through the interactions and the engagement of how our staff treats people. Do they feel cared for in the tone and the way that things are done? So it's not just that they're treated with courtesy, but they actually feel care, which is another line in the sand that adds I think a significant thing. And so in the future, we're going to be doing research on this and looking at how well do these scores correlate with different clinical outcomes in terms of suicide risk? Because you can match it up in the medical record, even if the staff's not seeing what people's answers are, to people's demographics, to clinical outcomes, and different things of that nature, to further a research body of how does someone's perception of being cared for impact their suicide risk over their stay, or vice versa, or how well are we engaging people over 60, or different demographic groups. So you can see that these are tools in the future that we don't really use right now to measure how well are we connected to people. And then finally, we added this in as, again, going away from one of the peer power practices that we talk about is being strengths focused and not just focused on an illness or a diagnosis. And so we collect vital signs, we collect pain, we do a pain scale on a person's perception of pain. But the goal of this group of 3 questions, and it's modeled after use of many questions of these same 3 questions that we used in outpatient pre and post feelings and outcomes of different interventions, is to question these 3 questions about feelings of recovery in that person, that we do just like we do vital signs on a once per shift statement done by our peer support with a 1 through 4 scale. But it's not just part of the peer work, it goes into the medical record. For example, if I'm a psychiatrist, open up a psych note, I'm going to see that that person is maybe a 1 in their level of hope and recovery. And that's something that the whole team is going to be aware of and be able to help. So it's a subjective opinion of my sense of recovery in some different domains that tracks either improving or not improving, to add a clinical data point measure to start measuring this. And in crisis world, that's really important, because sometimes you're only working with someone for 24 hours, 48 hours. And this is something you could use longer term. But definitely in our crisis world, we wanted some type of clinical measurement to be able to be a grounding force for that.
Absolutely. I love the options and opportunities for just to get in information and to make sure that everyone is getting the care that they need.
And this is just a repeat. If you're a bit more of a visual learner than things that we said, these are the 5 major peer power practices that we emphasize in our training and in our daily walk of what we do. And so the future, I hope, is that we can continue to move towards all layers of staff, not just people with lived experience and not just peer staff, but all layers of staff using these principles. I think they're important to connecting with people and to helping them improve their crisis in an even more robust way.
Absolutely.
So I'll talk a little bit, one of the other essential care principles is safer suicide or zero suicide principles. And so as you set up your system at all 3 layers of call lines, and actually through the whole continuum of a campus of care that you're going to set up for your crisis system, you want to think about core principles that are evidence-based or best practices related to suicide prevention. And zero suicide is all about the concept that within a healthcare organization, if they follow these certain elements, there have been examples where large healthcare organizations have been able to have literally reduced to zero suicide in a year by enacting these principles. And it includes having an evidence-based practice of screening tool that you screen everyone about suicide risk with a tool, and then people that test positive for that screening, that you're able to do a deeper dive of assessment of risk. And that then if they have a higher risk, that you actually you actually want to support doing direct treatment of suicidality. So not just treating the depression, hoping that will help improve the suicidality, but working with someone, what's the one thing that we could work on together that would help you feel less suicidal? Another piece that's really important in suicide prevention is follow-up plans and connections. And I see in the future technology being an even greater cohesive connection. We use it in our lives to connect with people all the time via social media things and apps that we use. And I see that as a future thing. And there's an example of this app right here, NowMattersNow.org, done by Dr. Ursula Whiteside, that is a tool that allows you to have immediate access to different direct treatment of suicidal thoughts and have your safety plan and contact supports listed in those apps. And that goes back to the final piece, which is using collaborative safety planning, which is a partnership, kind of like a wellness recovery and action plan, but designed specifically for suicide risk, where you look at your triggers, what things can you do that are good distraction techniques to help you cope with suicidal thoughts. But when you're in an emergency related to suicide, having connections to immediate knowing your tools right there in front of you, knowing what to do, and that you share that with friends, family, your outpatient providers. Technology in the future, there's apps that are free on your phone that have some of these evidence-based tools connected to them that not only let you see your plan on your phone, but again, can automatically, you can have contacts stored so that you can FaceTime someone immediately if you're, in an emergency related to suicidal thoughts, and use those things. But it goes back again to that data technology piece and access that's going to be important. So just was kind of recapping some thoughts about the future of making sure that we weave best practices into this care model.
Absolutely. So we have about 2 minutes, I think, before we move to question and answer. So I'm going to skip forward a little bit to something that is really important for us as we're looking at the future of care. And for us is really looking at the disparities across the board, but also specifically with individuals that have opioid use disorder, and how that care can be incorporated into the crisis continuum. It is not common for opioid use disorder care to be incorporated when someone is in crisis. It's usually something that's like, well, that's not kind of what we do. We're going to send you over here. And we are seeing a lot of disparities. I can't talk anymore. Specifically within that population, when it comes to insurance, when it comes to access. There's a study done that showed that individuals of color are 37 times less likely to even be offered evidence-based care when someone has an opioid use disorder. So this is a population that has historically been not included in crisis care. More looking at options related to abstinence only versus medication-assisted treatment, more criminalization than care. So for us, the future is looking at how do we support individuals that have opioid use disorder, with the realization that we are in the third wave of an opioid epidemic, where we have continued to see these waves over time continue to come and impact different communities since the beginning, but now it has seen a serious impact across all communities, and especially communities of color as well. So one of the things that I'm just gonna quickly mention is about being able to include that care within the crisis continuum space, making sure it's clinical fit to need, looking at the access to care. There's a lack of providers that are willing to kind of get involved in the medication-assisted treatment or harm reduction models, those things. And so looking at that is going to be a part of the barriers going forward. And then also looking at recovery focused care, making sure there are peer supports and engaging family involved. There's care for women. Evidence-based practices are being used, and we're actually not only involving the care in the crisis continuum, but we're also moving the care for individuals with opioid use disorder forward, so that we're using a very engaging harm reduction approach and not a very consequence focused approach to care, which is going to be something that's so important moving forward. And this is just quickly one of our campuses in North Carolina where we've actually done this. We have moved forward in using a harm reduction model, and also being able to not only continue someone when they're on and medication-assisted treatment, but also provide that care and start them on that care. Parity is so important. So making sure that just like we would start someone on medication for their mental health, if that was their recovery plan, we would treat physical illnesses because that is important as well. We're also doing the same thing for substance use disorders. Going forward, that's something that we're going to have. Right now, there's several lawsuits within detention centers, states, and all of that, pushing that parity forward to make sure that medication-assisted treatment is included in care as well.
So the tidal wave is moving forward of a lot of momentum to make future changes that help support bringing some of this to reality. And, we were Joy and I on a really powerful national 988 call talking about the history of development of 911. And I learned a lot of things about how it went wrong at the beginning before it ever got to where we are now. And so a cautionary thing to think about is to make sure as we're designing the system that we're, as we've been saying all along, that we're thinking about a lot of different angles at it and learning from history to make sure that we move it forward in the best way that we can. And I hope that this talk has been helpful in kind of summarizing some ideas about what that could look like.
Absolutely. So these are just some resources and websites to get additional information about what's going on, how the future is moving forward. And now we're at our time for question and answer.
Thank you, Joy and Chuck. That was very informational. Appreciate it very much. We don't have anything in the chat box now. Do you guys have anything that you would like to offer as closing remarks?
Nobody's punched out their future, what they think or has any ideas. I know we covered probably just a tiny portion of the things that are going to be important as we move forward. So anybody got any thoughts or would like to share?
I think Chuck and Joy, this might mean that you've done a very good job of covering the material.
Well, one other angle I just thought about to add some other things, if you think about the future, is we talked about this in part 2 when someone asked a question about it, is the development of crisis services for youth and adolescents because they are different in the needs and the scope of what needs to happen there. But there are a lot of similar principles to this crisis now impact and a need for doing that. But that's definitely one that we didn't discuss in the future of this or what it might look like. Another realistic thing that's got to happen, that's fair and needs to happen in the funding aspect of this, is to put political pressure from a parity standpoint on Medicare and private insurance paying their share of behavioral health crisis. So literally, if someone with a private insurance comes to most typical crisis centers across the country, they're going to get services if they're truly no wrong door and take people in, but their insurance company's not going to pay for it. It's going to come out of funds designed for folks who are uninsured or low income because of the way the system is set up. And so that's an important piece.
Absolutely.
So we do have a question that just came in and a comment. It says, great presentations. How do you work with licensing to be able to accept all individuals who present without turning anyone away?
So I can take that question. So one of the ways that we do that is through having what we call a 23-hour observation unit, and what that is a lower level of care. And in different states, it's kind of called different things and licensed differently. In North Carolina, it's licensed, is looked at as outpatient. In Louisiana, it's under what we call our CRC license. It really depends where you are. But what it is it's the equivalent of an emergency room. So when someone comes, they are immediately admitted into that space. And because we're able to have that level of care, where the expectation is that you will be as an emergency room and admit everyone, and then figure out through assessment, evaluation, connection, and engagement, where they go from there is really how we do that no wrong door practice. On those same units, we also have or in those same buildings, we also have what is considered like a higher level of care where there's a longer term stay. 3 to 5 days is usually our average. And what that is, there is a higher level of care that's needed for someone. They are then transitioned into that space. If it's a hospital that they need, then they are transitioned and, you know, referrals done for inpatient if that's the care that they need. If we need to reconnect them to an ACT team or to their outpatient provider or something like that, we can do that from there. So it's really having that, we call it our retreats, but it's a 23-hour unit that is designed to accept everyone and then be able to keep the average length of stay under 23 hours. So we're doing observations, assessments, evaluations, and then kind of moving people from there. The same as if you went to an ED, you're admitted, they do their tests, they do their assessments, and then they determine what it is that you need, and they transition you to that level of care immediately. So that's how we're able to do it. And it's just really licensed differently in most states.
But the majority of the states, I think, Joy, typically funnel under that outpatient rule.
Mm-hmm.
It helps from a billing perspective of funding the service to be able to do billing for the assessment. It also helps in throughput and capacity in that, you know, you can have 25 chairs in an outpatient center. It's very different than a 25 bed unit where you're going to come into IMD laws and you can't go over 16. So it allows for flexibility. It allows you to say, you know, if you have a capacity of chairs of 20 and in 1 hour, 3 more police cars show up and drop someone off, you don't have to say no to those officers because it's not a bed cap, and you're going to have flexibility and throughput to be able to, you know, open up 3 more chairs before those 3 people come in. So every once in a while, those temporary observation units, we have to go on hospital deferment where we can't take transfers for hospitals, but we never say no to officers, and having it licensed as outpatient in most places helps allow that. And one other licensing thing that's really important is being designated for involuntary commitments if you want to be able to accept all, or otherwise, then that's not a place where people who have been petitioned for safety reasons, they can't access that same level of care. They're going to end up probably going to an emergency department or something if you don't have that built in your licensing and certification.
Yes.
So thank you both for that. We are at time now. We'd like to thank the presenters, Joy and Chuck, and thank you all for attending. Joy, would you please? Thank you. So thank you for attending, and we need to hear from you to keep bringing you these free resources. So please take a few moments to give us your feedback. We used to plan it in the future learning opportunities. I will be sending this out. In fact, you should be receiving the link for this feedback in your chat box right now. Just click on it and it will take you directly there. It only takes a few moments. Thank you very much for joining the presentation.
Thanks, everybody.
Thank you.